Anemia is defined as the qualitative or quantitative diminution of RBC and/or hemoglobin concentration in relation to standard age and sex and is clinically manifested by pallor. It is not a disease but denotes manifestation of some disease. Symptoms: weakness, fatigue, lassitude, lightheadedness, giddiness, fainting or syncope, anorexia, palpitation, breathlessness, anginal pain, insomnia, tinnitus, lack of concentration, intermittent claudication, tingling sensation in extremities. Important history. Present history. Patient complaints of easy fatigability, shortness of breath and decreased effort tolerance. Past history. History of bleeding, for example menorrhagia or hemorrhoids. History of blood transfusion in the past, chronic diarrhea, suggest possibility of tropical sprue. Personal history. Alcohol consumption, walking barefooted, can cause hookworm infestation. Family history, similar type of disease in family suggest genetic inheritance. For example thalassemia, hemophilia. Dietary history. Important to diagnose nutritional anemia, for example pure vegetarian, suffer from vitamin B12 deficiency anemia. Less intake due to anorexia, dysphagia or poverty another cause for nutritional anemia. Treatment history. Should be asked for ingestion of bone marrow suppressant drugs like methotrexate, NSAID intake or history of radiation. Occupational history. History of exposure to chemical solvents, lead, benzene, insecticides should be taken. Geographic background and ethnic origin. Sickle cell anemia is common in India, Maharashtra tribal regions. G6PD deficiency common in African and Asians. In short, following history should be taken. History of chronic blood loss, for example, bleeding peptic ulcer, hemorrhoids, menorrhagia. Malabsorption, for example, diarrhea steatorrhea. Nutritional intake, worm infestation, exposure to drugs, chemicals, radiation. Bleeding tendencies, bowel habits, anorexia and weight loss. Algorithmic approach for anemia diagnosis. Anemia, common causes. Iron deficiency. Anemia of chronic disease, chronic renal failure, acute blood loss, vitamin B12 deficiency. Myelodysplasia, chemotherapy. To find out the cause, measure mean corpuscular volume. If there is low MCV, check serum iron levels, total iron binding capacity, serum ferritin level and HB electrophoresis. Anemia with low MCV suggest following differential diagnosis: iron deficiency anemia, thalassemia, hemoglobinopathies, sideroblastic anemia and lead poisoning. The table below summarizes the changes in the various laboratory indices, which will give you a probable diagnosis. If MCV is normal, check serum iron, total iron binding capacity, serum ferritin. TSH, blood urea nitrogen and serum creatinine. Anemia with normal MCV suggest following differential diagnosis. Anemia of chronic disease. Chronic renal failure. Hypothyroidism and dimorphic, that is mixed microcytic and macrocytic anemia. If MCV is high, check the reticulocyte count. Depending upon increase or normal reticulocyte count, we can diagnose specific cause for anemia. If there is high MCV with increased reticulocyte count, check indirect bilirubin. If it is raised, it indicates hemolysis. Now we have to think of common causes of hemolytic anemias. It includes G6PD deficiency, pyruvate kinase deficiency, hereditary spherocytosis, hereditary elliptocytosis, mechanical heart valve, viral infections, SLE. Medications like methyldopa, quinidine and penicillin can cause hemolysis. In cases where high MCV with increased reticulocyte count present, but indirect bilirubin is normal, we can suspect acute blood loss, like trauma, epistaxis, menorrhagia, hematemesis, hemorrhoids, diverticulosis. Now last part of this algorithm. High MCV with normal reticulocyte count. Common differential diagnosis includes vitamin B12 deficiency, folate deficiency, alcohol abuse, liver disease and myelodysplasia. Medications like sulfonamide, phenytoin, zidovudin, and chemotherapy can cause anemia. Thanks for watching. Do not forget to subscribe the channel.